the process this morning that your facilitators will be inviting you to engage on, okay, is going to be this. It's going to be in two parts. So if you're in surveillance, Alain's going to be asking you the following question. He's going to say, look, if we look at surveillance, what's our vision of success for really great surveillance? A few minutes to sort of talk about what does that look like in your view? Let's sort of brainstorm around that. Okay, then stop. Then right after that, okay, what ideas or what steps should we take to move towards that? What ideas do you think should be considered in the development of a federal framework on surveillance? Okay, so it's the what, so we can sort of see, you know, what do we want to achieve together in terms of surveillance as a case in point, and then how do we actually do that? What ideas do you think should be considered in the preparation of a framework? Okay, and by the way, many of you have said, look, there's some urgent stuff. We need to deal with some stuff now. So please think in terms of what should be done now, in your view, in the short term, what could be medium-term stuff, and what could be longer-term stuff. But be clear in terms of what you think needs to happen now, okay? So, on that note, I wish you a terrific morning. Je vous souhaite une matinée incroyable, and this is the time to generate your ideas. So have a great conversation, and we'll see you back here at 1. All right.
So your first question is to envision a better future. Don't worry about the timeline for that. But I'm asking you to imagine a future where the issues have been addressed and the guidelines and sharing of best practices, specifically because that's our focus here in this room, and the others are doing visions around education and awareness and surveillance. But a future where guidelines and sharing of best practices are working for everyone, okay? What does that look like? Project yourself into that future and imagine what you would see. And then have somebody in your group take notes for the group of that vision. And what we'll do when we come back into plenary is I'll ask a few groups from different places in the room to share their vision. And then I'll ask the other groups to add any elements that they might not have heard or that they want to emphasize. So I won't go to absolutely every group to have you recite your vision because we could be here for 3 days instead of a morning, okay? Is the task clear? Are there any questions on what I'm asking you to do here? But for 15 minutes in small groups, try to get as much of a mix of views as you can in your groups. Really talk about what would be success from all of your perspectives. What's your vision of success? I'll start with you. A minute, I just want to make sure you have everybody's attention. And don't forget, we'll also be going to folks on WebEx. So I might not get to everybody, but let's see how we can do this. Go ahead, please.
Okay, and I apologize because we jumped around a little bit once we started talking a little bit more, so if it does have a pattern in my brain. So we wanted to have defined and reviewed guidelines that is done by the medical profession, so it's got to include healthcare providers, naturopaths, and everyone involved in the entire body. We need consistent updates that is mandatory for all medical professions to make sure that they're all on top of what's going on, at least yearly. Oh, I just know we're on a time constraint. Move closer than that? Okay. How's that? I can. So we want defined and reviewed guidelines yearly by the medical profession. That includes healthcare providers, naturopaths, anyone that's involved in any part of the body that actually can contribute to what happens with people with Lyme. Consistent updates that is mandatory for all medical professions, at least yearly, with special updates and bulletins always issued so that everybody is in the know at all given times. Students need, in the medical profession and and that includes, again, naturopaths and everything, need a segment on what Lyme is and need to be trained right at the university level. We need more immediate diagnosis, and we're suggesting that we have a test that detects early, and it's like a pregnancy type test. Either you have it or you don't. Prevention on the longer term, we want immunization to look at reducing the primary pool, remove the pathogen and the vectors. We want best practices created for all healthcare professionals that, again, are reviewed annually. We want to be equal partners with healthcare practitioners, so it's just not a one-man cowboy with one opinion that stands against all. A central reporting system to keep track of what is working for patients and what is not, that is accessible by everybody. So it needs to have a multiple discipline approach, not just infectious disease. It's got to include cardiologists, environmentalists. It's a multi-systemic disease, so we need functional and integrated doctors, nutritionists, anyone that understands the pattern and may have an impact on the treatment, not just antibiotic results, it's everything. We want doctors to be able to be more open-minded about thinking outside the box and have the ability to do that without fear. We need to remove the fear. We need multi-centered trials, multinational and national, so that we can put all of our knowledge together and start moving forward as a group. And we need to also look into research of what's keeping people healthy and why some get it and why others don't. There might be more in the body that we have at our disposal that we're not using. We want a review of all of the years of misdiagnosis so we can catch up with the people that have been left behind. So we want a national program with multidisciplines involved, continual review of guidelines, and just keep moving the game forward. And I hope I did this well. That's it.
And so I'm sensing a blend of vision for the future and how we get there, but we'll start with vision for the future. So thank you. Another person from the room, go ahead.
Okay, we have a dream. Our dream is that Canada will be a world leader in Lyme disease research, treatment, diagnoses. We have a dream that the Magnotta Foundation its work will be done, its clinic will be there, its diagnostic facilities will be there, its research labs will be there, its clinics, its testing, its treatment of Lyme disease will be there, and there will be other centers across the Canada that will duplicate that work. We have a dream that together with patients that these foundations can be overseen by boards of individuals who are interested in the care and treatment of patients. One of the ideas was that perhaps rehab medicine would be the best people to oversee these because they are working on getting people better. We believe that doctors should be protected now for treating patients, and that we should not stick to the strict guidelines that the IDSA has put forward for treatment. We need a test. We believe that in our world we will have a test that is reliable, a test of active infection and co-infections that is reliable now. We believe now an immediate win would be education of physicians and any healthcare practitioners around Lyme disease and a patient-oriented care, that we stop thinking about anything other than the patients. I'm just going to look here quickly. Our goal is to get people together. This actually activity at our own table broke down huge silos for us and was a big step in going into the right direction. So thank you for that opportunity. We need to remove limiting barriers. We need to have all types of professionals at the tables. Holistic approach would be best. And we absolutely need balanced relationships between doctors and patients.
Wow.
Thank
A special
you,
microphone.
So we had some comments about what we envision in our ideal guidelines, and then a few other quick comments about what we think is needed in the context of the guidelines to be best implemented. So we recognize that there's both the acute presentations of Lyme disease, but also some more chronic presentations that have been less well accepted and recognized historically. And we need guidelines that accept and recognize both of them and start to break down the stigma, particularly for the more chronic presentations. We need these guidelines to take a holistic approach and take into account all the different modalities of treatment that are available to make sure that patients who maybe aren't being treated, getting the care, the relief they need along one guides, can get it from some of those other disciplines. We need the guidelines to no longer have the conflict where we have the IDSA guidelines and the ILADS guidelines on conflicting, and somehow integrate the best of both so that there's the best treatment for everybody within these final guidelines. We need the guidelines to really recognize that there is a risk of Lyme disease everywhere. While there's endemic areas where the risk is highest, ticks can be found anywhere carrying the Borrelia bacteria, so the guidelines need to recognize that. The guidelines need to continue to emphasize that treatment must be based clinically and shouldn't be reliant on the lab test. Even if the lab test is 95% accurate, that still means that it's going to miss 5% of people. So we need to make sure that the clinical picture is not lost in that. And we need to make sure that whatever guidelines are come up with, that they are promoted, that it's educated across the healthcare system so everybody's fully aware of what the recommendations are, because right now a lot of people aren't being treated appropriately because they're seeing a clinician who is not fully aware of what the current guidelines are. And then secondarily, we thought there's a couple of contextual pieces we need so the guidelines can be appropriately used. And that is, we need to have rights for physicians to treat according to their best clinical judgment, with protection that they're not going to be persecuted because of this. But similarly, we need rights for patients to go seek out the treatment they need and not be barred from access to health care within Canada because they're seeking health care from elsewhere. And also to have some avenue for patients to potentially be reimbursed for the care that they seek elsewhere.
Okay.
Good morning, everyone. It's a pleasure to be here. I'm Dr. Mulaney Wills from the University of Guelph, and I'm very proud to say that our table achieved, I think, the perfect representation that you were asking for. We had research science, we had patients, we had patient advocates, and public health. And so what does our vision of the future look like? I have a bunch of bullet points, and I know that they overlap with what's already been said, but that doesn't make them any less valid. Patients are partners in care. They are treated with respect and compassion. Patients need to be considered experts in their own personal symptoms. We need multidisciplinary, integrated care. We need confidence in our medical system. We need prompt and adequate intervention in the acute phase before chronicity sets in. We need authentic acknowledgement of long-term chronic trauma that patients have suffered in attempting to access help. We need medical supports and psychological supports for patients in these positions. We need dedicated treatment centers with a team of multidisciplinary healthcare providers who are knowledgeable on the topic and offer appropriate intervention. Patient input on the composition of these treatment centers is required. We also demand engagement of the social sciences as well to bolster outcomes of biomedical research, as they tend to be well positioned at doing qualitative research and engaging patients. Thank you.
So going to WebEx now, is there anybody who has the time and the context where you could come up with a vision statement?
The first comment is from William Baker. Please go ahead.
The vision that we have for moving forward, as the kind gentleman that just spoke earlier with the glasses and the Jose Bautista-style beard, I believe he is from the Niagara region. He spoke about being persecuted. And that seems to be the problem with our poor doctors throughout Canada by the College of Physicians and Surgeons. So moving forward, immediate help, medical help for those who are infected, suffering, and dying, including children. This would look like lifting all sanctions on doctors by the College of Physicians and Surgeons on doctors who diagnose and treat Lyme patients. Currently, doctors are not permitted by the college to use clinical diagnosis for Lyme. They are severely reprimanded and threatened with loss of their license. Treatment is restricted to IDSA guidelines only, and they should be allowed to use their educated judgment with the ILADS guidelines, and they should be permitted to do so. Doctors need to be directed and allowed to treat patients according to their knowledge and history of patients' illnesses and suffering. There are now no doctors in Toronto, Ontario, or Canada that I am aware of that treat Lyme disease out of fear of persecution from the College of Physicians and Surgeons. Patients are therefore having to flee the United States at great expense and suffering by Lyme patients to seek treatment. We cannot afford treatment by U.S. doctors, and most patients are far too sick to make the long journey for the treatment. In summary, doctors must be released from the strong arm of the college so they can practice as they see fit. This is of immediate importance. Time of treatment is of essence, particularly to those that are dying and sick. The public communique to all physicians and public notifying doctors that they may treat Lyme patients by IDSA or ILADS treatments. The reporting of Lyme disease to the Public Health Agency is severely restricted due to the fact that doctors cannot or will not treat Lyme or diagnose Lyme. Therefore, they don't report to the public health agencies.
Okay, thank you very much.
Thank you.
Okay, thank you.
Thank you very much.
Hi, everybody. I'm Maura Lippert. I'm from Guelph, and I'm a holistic nutritionist. And I do not have Lyme, but I look after a lot of clients who have Lyme. So this has been very helpful. These are the thoughts from our group. They're a little here and there, but I think that we've brought them together in somewhat vision. What was important to us. We talked a lot about evidence-based guidelines based on research questions that need to be very specific, and guidelines built on best evidence and full transparency. We talked about data should be objective plus subjective, qualitative and quantitative, all need to be included. We discussed test results and how patients need to have access to test results with the full information, not just summaries, and they shouldn't have to file certain paperwork to get them. Test results should not override a clinical diagnosis. We talked a lot about transparency and inclusion of not only this process, but going forward in order to build trust, because there's been a lot of broken trust that we've heard over the weekend. So building of the framework itself needs to be a transparent process on an ongoing basis, plus implementation of the guidelines. And lastly, we felt that there was a lack of representation at this conference in the terms of medical professionals and experts that were not medical doctors. Thank you to the medical doctors who spoke, but there are a lot of other healthcare practitioners that are having success with Lyme patients who do not have an opportunity to speak, and we think that's a huge gap. Like other groups, we would like to encompass a broad range of functional medicine and integrative medicine caregivers, including, naturopaths and acupuncturists, functional medicine doctors, physiotherapists, registered holistic nutritionists, because diet is important, and we haven't really talked much about that. That's my thing, sorry. And osteopaths. So that's our group vision, and we look forward to seeing the outcome. Thank you.
Thank you. Before I go to someone else in the room, I'll check again with the WebEx operator. Do we have someone else queued up for stating their vision? Remember, we're looking to the future, and we're trying to add new here rather than repeat things that have already been said. Go ahead.
Yes, the following question or comment is from Echo Armstrong. Please go ahead.
Hi. So what I was thinking would be a great add-on and maybe something that could be implemented quite quickly was a patient advocate / patient liaison that worked within the medical community. I know that there is a lot of agencies like CanLyme, or I'm here in Alberta, and we have the Alberta Lyme Association, which are wonderful and great advocates, but something within the medical community that's more acknowledged by them. I think there's almost a brush off that's happened so far, and with that patient advocate, they could help people that are chronically ill like myself who don't have the energy or the resources to self-advocate. Right to this point, when I've gone in, I'm so traumatized by the medical community, I can't even go by myself anymore. I have to take my husband because I'm so scared of what has happened, because I've even been told off by doctors. about how what I don't have is real. So it would be, the advocate would be responsible for, or an advocacy office, so probably not one person, that could come maybe to the visits, or have volunteers that could come with you to the visits. They could liaison with doctors that maybe don't quite get it, or are having a hard time making a transition into the new information. They could advocate for us to be incorporated into research. Now, whether that's our own personal experience or just getting out to us that there is research and they're calling for participants. They could help us with recourse if there is an unprofessional person out there that has traumatized us. And they could maybe just help in terms of giving us the skills to walk into those doctors' offices with confidence, because I know myself, after 8 years, I'm frightened to go to the doctor now. I'm scared.
Okay.
And I feel like we need some advocacy within the medical community that the medical community itself acknowledges.
All right.
You know, whereas right now we're outside of that.
Okay, so patient liaison and advocacy within the medical community is the vision that you're sharing. Thank you very much.
Hi, I'm Dr. Ben Boucher from Nova Scotia, and I unfortunately am one of those Lyme literate doctors forced into early retirement. Our group's vision is a timely diagnosis and treatment goal to eradicate infection. ILADS type training for infectious disease, family doctors, and potential Lyme literate doctors. Allow ID and non-ID doctors to treat according to their knowledge and patient needs. Remove dependency on test results and treat clinically until reliable tests are available. Recognize that there are other vector-borne infections than Lyme and from more than ticks. Recognize that infected ticks are also in non-endemic areas and not necessarily seasonal. Create centers specialized in vector-borne infections. Diversify guidelines to incorporate a variety of possible vector-borne infections. Create positions of national and provincial patient advocates. The status quo is unacceptable. We need change now, and we need to treat patients with respect and fairness.
Thank you. Try for now to focus on what does the picture look like in the future, because we are going to come back to say, how do we get there? Go ahead.
Great, thank you. My name's Christina Malloy, and I'm from here in Ottawa. In terms of our vision, we came up with 4 different areas. So the first is reliable testing, including a broader definition to include all of Lyme borreliosis. And then as other aspects of testing, there would be accurate testing of ticks available, and a longer-term future view is also a point-of-care test so that it can be available to patients right at the doctor's office. Similar, we were talking about the example that you can get for your dog at the vet. The second area is treatment guidelines, which have been spoken about. So, but that these treatment guidelines are based on Canadian research and clinical trials that need to happen before that point, and that they cover off each phase. So we spoke yesterday around acute, post-treatment, and chronic Lyme, and that there isn't the current focus so heavily on the presentation of the bullseye rash. And that as a subsection of this, that there would also be Lyme literate physicians, which we've spoken about across all specialties. So whether it's mental health professionals, internal medicine, infectious disease, etc. The third area is the recognition of Lyme disease in all its forms by doctors in the medical community, disability and social supports, as well as insurance, so that the financial burden can shift away from the patient. And then the last part is coming up with an effective vaccine. So ultimately, again, future goal, a vaccine that can be reliable and doesn't require multiple boosters, and that we can count on. That was our vision.
Thank you.
Thanks.
There's still energy. Okay. Again, we're trying to keep it short because I really want to spend a significant amount of time on your ideas for moving forward as well. Go ahead.
Burn through this. My name's Gwen Barley.
Not too fast.
And won't burn through it that fast. And I'm from Vancouver. And our table, can you put up your hands? We had an amazing table and generated a lot of great ideas. So first off, we wanted to see protection of doctors who exercise clinical judgment and in particular treat beyond the IDSA guidelines. Suspend two-tier testing, clinical diagnosis acknowledged as having supremacy, remove misinformation online, for instance, that 80% of patients show perfect bullseye rashes, acknowledge that Lyme disease is a borreliosis infection and also that it often is accompanied by co-infections, include in definitions of Lyme disease definite cases, probable and possible, and have all of those cases reported to public health agencies, that GPs have the ability and authority to diagnose and treat and take over treatment for this chronic condition. A majority of guideline panelists should be from the primary care specialty, recognize holistic treatment, and in particular allow patients to claim expenses for insurances and taxes, particularly if an ND or a GP prescribes. Research patients to be involved in design and funding allocation. Transparency, having open communication channels. And for instance, there was a Queen's invitation-only science conference about 2 or 3 weeks ago that was about Lyme disease. It'd be very helpful, I think, to people in this room to find out what the conclusions were from that conference. Reduce, ideally, the dichotomy between the two camps. Have accountability in the development of guidelines. What's the timeline and how are patients going to be involved and their representatives in the development of those guidelines? Help to ensure the integrity of the blood supply in Canada for Borrelia and especially other tick-borne infections. Capture cases of chronic Lyme disease. I'm getting close to the end. And then I have one that wasn't brought up but I think is important. Need transparency around the use and misuse of pre-test probability models on positive test results. Longer term, we'd like to see tissue sampling and a biorepository established and not controlled by one group. And Canadians deserve treatment in Canada that is between holistic and AMI guidelines. Guidelines need to acknowledge and discuss unknowns and knowledge gaps. A Canadian version of ILAD's considered sexual transmission be explored, and guidelines need to be routinely updated as knowledge and research progresses. Thank you.
We have a few more in the room, and I'll go back to WebEx for one more before we close this segment. Go ahead, sir.
Thank you. My name's Tom Ranke, and I advocate for my wife. I'll try not to list the items that have already been talked about, but quickly, family doctors must be aware of tick bites and best practices, and quickly get to giving 30 days of antibiotics. I mean, that's just a given. Support by insurance companies was mentioned, but also employers, workplace accommodation. A lot of people, they're sick, but they want to work. They want to contribute and be part of society. Patients should not have to train their doctors. It seems like that's where all the effort it seems to be going. Patients should receive an overall holistic plan of action for their. It doesn't have to be. They shouldn't be just given instructions for this one visit, but how should they live their lives? Like put some context to all this for their health. And I think we also earlier mentioned a possibility of a Lyme literate designation for Canadian doctors.
Okay, thank you.
Hi, my name is Michelle Gagnon. We need Lyme literacy in healthcare professionals. Physicians need to understand the different dimensions of Lyme. We need a patient-centered approach. Every person responds differently, so treatments need to be different for everyone. Tick bites need to be taken seriously and treated properly immediately. The whole experience of this whole group is very important. We need a national database. Most people here are probably not included in the national database. We need that to change, whether it's an online thing that people fill out and, whatever. It's very important because everybody in Canada needs to know the real numbers, so it's taken seriously. Doctors, I know, laughed when I had hope that things would change from this conference. So I really think the College of Physicians needs to be on board, and they need to allow the doctors to treat without fear of losing their license. This is number one priority here. And perhaps an online Lyme literate doctor could be hired right away, and doctors could be able to access this online person to be able to give recommendations for doctors, because it's a very complex illness, as we all know, and a Lyme literate doctor is needed for correct treatment. As far as education goes, many are getting Lyme from dog ticks. So people need to know it's more than black-legged ticks, and patients should be treated with respect and should be treated based on symptoms regardless of a known tick bite or endemic area.
Thank you. Just before I come to our last person in the room, I'm going to go to one last person on WebEx, if that's okay. All right. So do we have anybody else on WebEx?
Great, thank you. I'm Caroline Stengel. I live in Victoria, BC, and I brainstormed in my group of me, myself, and I this morning. If despite excellent awareness and prevention, this is like in the future, my future vision, if despite excellent awareness and prevention, if I still got sick, doctors would be kind, respectful, and open-minded and good listeners when I went to see them. Family doctor would immediately suspect Lyme or other tick-borne infections when I came to the office with a tick bite, and preventative treatment, whether it would be antibiotics or a future cure or other type of treatment, would be offered immediately and would be fully covered by the provincial health care plan. If there was no tick found, if only symptoms were presenting, the doctor would include Lyme and tick-borne infections in her or his workup as conditions were ruled out. Testing would be extremely accurate and reliable and would test for a wide range of wild strains of Borrelia as well as co-infections. Test results would be fully disclosed to doctors and patients, and clinical diagnoses would be used and recognized, and we wouldn't rely on test results unless they were extremely accurate. Reporting of Lyme and co-infections would be straightforward, simple, and would result in accurate statistics. Doctors would be able to get training to become Lyme specialists, and just our general family physicians would be very knowledgeable as well. Restrictions on antibiotic treatment and other kinds of treatment for Lyme and co-infections would be lifted, so patients could be treated according to individual need until they get better. Lyme specialist doctors would team up with Lyme specialist naturopathic doctors and other types of health practitioners to create comprehensive treatment plans that support the whole body's recovery. IV antibiotics and oral antibiotics would be readily available to Lyme and co-infection patients, as well as supportive therapies. Nurses would be trained to treat Lyme patients with IV in their homes as an option, because it's often very difficult to get out of your house when you're very, very sick. All treatment would be covered by the provincial health care plan and health insurance. There would be no arguments about covering for Lyme treatment. And Lyme and co-infections would have as high a profile in the media and in the medical community as cancer. You wouldn't get those blank looks anymore. People would be instantly sympathetic and want to help. Disability programs would recognize Lyme and co-infections as legitimate disabilities. We wouldn't be losing our insurance coverage because of this whole controversy. General practitioners would be very knowledgeable about every stage of Lyme and co-infections. Blood banks would screen vigilantly for tick-borne infections. Pediatricians and OBGYN docs would be very knowledgeable about preventing transmission of Lyme and co-infections during pregnancy and would treat infected infants and children very effectively. Research would be generously funded and prolific, a cure would be found and made available. And green ribbon events similar to cancer fundraisers would be commonplace and endorsed by big corporations and government, and we'd have so much support that we'd all get better. Thank you.
Thank you. All right, the line has proliferated again, so I'm going to ask all of you to be very, very brief because we need time on how do we get there. Go ahead, please.
My name is Esther Ann Davies, and I live here in Ottawa. A lot of what we've discussed has been mentioned, so I'm just going to focus on the ones that haven't, okay? So basically, in our perfect world, not only would we have immediate testing when we went into the doctor and immediate treatment, as has been discussed, but our doctors would have access to these centers of excellence that are being discussed. But in those centers of excellence, we would have ILADS trained MDs, NDs. They would be the equivalent of what I would like to say the Heart Institute here in Ottawa. They would be known worldwide for the research that was being done, for the treatment that was being offered. And from a research point, we would be looking at what is being done in the world and not looking at how to pick it apart, and instead we would be looking on how to expand on it, how to move forward and actually bring our country to the forefront of research and treatment in Canada, which is where I believe we should be. Also, in order to make that happen, though, research needs money, grants need to be out there, and in order for people to get grants, there has to be widespread knowledge about Lyme. So education is key, and that's where things come full circle. But it would be nice to see Lyme disease as being researched extensively, just like HIV was done earlier on. We would also like to see naturopathic doctors included under the provincial health care so that we have a more inclusive approach to medicine where MDs and NDs can work together and both can be Lyme literate and can be supported and funded, but that we actually have a more holistic approach to treatment. Anything else I miss?
Thank you.
Pretty well? Thanks.
All right, very briefly, 3 other people in the room, and then we must cut this off.
Okay, my name is Julie, and I'm from North Bay, Ontario. And I would like to say that there was a mention of a patient-centered database, and it was suggested a database of numbers based on possible and whatever. I would like to continue to go further with that and say that the database should include treatments of patients so that our profiles are actually put in there. Unlike many of you, I actually was in remission after being treated in the States. I came out of remission because I picked up a virus and my immune system then had to work on too many things at the same time. So I'm no longer in remission. Even though I went to the doctor with the treatment that had worked for me personally, knowing exactly what would likely put me back into remission, I was still denied that treatment and cannot afford to go to the States. Now, if that data bank existed, maybe the first time they won't say absolutely that it cured me, but if it happens again a second time, that goes that much step further to prove that what works for me works for me again, and that could be used for other people. And if a database like that was created of these treatments that were working for people that doctors could access, I think it could help them in treating more people. The time thing is absolutely vital. Certainly, so many people, the early treatment is much more likely to fix the issue. But unfortunately, those of us who are in the late stages are not acknowledged by the doctor. I was dismissed simply because the tick was so many years prior to. By the time I went to the doctor, I was in late stage Lyme arthritis mode. And I mean, eradicating it from me is virtually impossible. But quick, yes, but also you have to recognize patients can arrive at any of those stages, not just the early one. The last point I would like to make is not specific to Lyme, but I think is extremely important and needs to be addressed, is our doctor shortage. I don't know what it's like across Canada, but in Ontario, we probably only have 25% of the number of doctors we require. So for me to be able to go to the doctor and have the amount of time that it takes to discuss not 40 symptoms, but 78 when I first went in, is just can't happen because we don't have enough doctors and they can't give us the time.
Okay.
Thank you.
Thank you.
Mine's very quick.
Yes, I need to go back up to WebEx for one more, and then I'll come down to you. So WebEx, please, the next speaker.
The following question is from Emily Holmes. Please go ahead.
Yeah, I think most of the things that I had down have been covered, and so I'm just the one thing was just simply that even if the patient doesn't remember a rash right away, but comes back and says, I do remember 2 years ago there was this rash, and they are experiencing unexplainable symptoms, that some type of treatment or testing should be offered. I guess that's pretty much all I have to offer, because I think everything else I had written down has been mentioned. Thank you.
Thank you very much. Appreciate your being brief. Go ahead.
Hi, I'm Julie Meikle. Everything that we had at our table has been mentioned. One thing that hasn't been mentioned is a husband advocate over here was talking about people who want to work. So the people that want to work, that especially do physical jobs, it would be really nice to have some kind of funding for education to re-educate the people that have physical jobs to do something else that they're capable of.
Okay.
That they can't stand or they can't lift things, for example.
So beyond the support by insurance and employers, that re-education,
the re-education, because we want to work.
Thank you.
Sure.
My name's Joanna, and I'm from Toronto. I'm not going to repeat what everyone else said, but there's something that I noticed was missing from everything everyone was saying, and that is great what we're doing moving forward, but we know what's happened in the past. Where's sort of the recourse for those of us who've already spent $100,000 or more? What's going to be in the framework that's going to address us and get that money reimbursed to us is the first problem. And what's going to happen, what sort of recourse do we have, a sort of database to report the doctors who did certain things that were above and beyond abuse that we could report, because those are the first doctors that you have to go to, and make sure that they're following any new guidelines you have, because they're going to be the most resistant.
Okay, so we're shifting into recommendations with this, so thank you. And you appeared magically. You weren't there last time I checked. Very, very, very briefly, because we need to move on.
To the point. My name is Cecile Goff. I live in Guelph, Ontario, and I have a recommendation. I recommend that we create an amendment to the Health Insurance Act, which is a provincial act. I'm asking for all ministers of health and MPs to get involved with this. I've spoken with Elizabeth May, Mike Schreiner, MP Ludwig, MP Lloyd Longfield, MPP Mike Mantha, and MPP Liz Sandals. I recommend that everyone, when you go back home, contact your MP and MPP. This conference is amazing. I think it's great that we are creating a framework and a strategy, but I'm calling on the government to create an emergency strategy, because this is an emergency. You recognize now, our chief medical officer recognizes the statistics, and there are those of us who are living with Lyme now who need help now.
Okay, we have moved beyond group reports on vision. Thank you very much. I have to stop the visioning reporting here because we're moving so far into recommendations and ideas for moving forward, and we need to capture as many of those as possible. So I'm going to do a very brief table discussion this time around. Document your ideas for moving forward. So how do we achieve that vision? A lot of them have come up already. I know there are people on WebEx who want to speak. I'm going to, when I open it up again, focus on that. Short term, medium term, and long term. Ideas for putting in this federal framework that will achieve the visions that you've described. If you need a break, it's self-managed this morning. There's not going to be a time for break, obviously. We're already almost at 11. At 5 after 11 by the clock here in this room, I will ask for what you've come up with. So a suggestion, the people on this side of the room start with short term. In the middle, start with medium term, and on the right, start with long term. So that way, if you can't get to all of them, somebody will have started on one of those and go to others as you move on. 10 minutes, group discussion. What are the best ideas that you can come forward for this federal framework so that we achieve your vision? 10 minutes. So, I apologize that we have a limited amount of time. I know you have tons of other things to talk about, but we do need to capture your ideas. And so I'm going to move to plenary now. The way I'm proposing to work it to make sure that we have a good mix, at least initially, and then we'll continue to fill it in as we go, is I'll start with a couple of ideas on the short term. So when I go to your table, I don't want all of your ideas. I just want 1, maximum 2 ideas to start, okay? Just so we start to get a flavor. And so those of you who are reporting for your groups, you need to be listening carefully. The same applies for those of you who are speaking on WebEx. Listen carefully to what others are saying. Please do not repeat, because we won't get to all the ideas if we're repeating the same ones over again, okay? So we'll go to short term, a couple of ideas in the room, an idea or 2 on WebEx. Then we'll go to the medium term, a couple of ideas in the room, an idea on WebEx. Same thing for long term, and then we'll do a mix. We'll go first come, first served, trying to balance out. I'm counting on you not to do too much repetition, because we need to be done by 12. We need to summarize everything that you've brought up and then report it back this afternoon. So we're kind of crunched here. Ready to roll?
My name's Tom Ranke, and our ideas were allow doctors, this is short term, allow doctors to treat with antibiotics in Canada without risk to their medical license.
Okay, thank you.
And I guess as one other, treat based on symptoms.
To treat?
Based on
symptoms.
Right.
Okay,
Clinical.
thank you. Yep. If you can hand the microphone back, and just behind you. Yes, go ahead.
Our first short-term goal is we would like to see Manitoba Canada Health put forward a moratorium for at least 5 years on doctors being allowed to treat as they feel is best for their patient. This is being done in Minnesota. They have a 5-year moratorium. They will not be harassed, they will not be hassled, and they will not be forced to retire out. So
okay, so that sounds like exactly the same idea I just heard from the other table. So I need to be careful, allow them to treat without risk and without punishment.
A moratorium is very different, though.
Yes?
A moratorium is the way to do it.
Okay, so
all right?
5-year moratorium.
Right,
One
and
more?
the second one is absolutely without question, patients must be brought to the table after this framework with equal representation to anyone else in that room. Because quite frankly, most of the people in here are better educated at what Lyme is all about than those who will be at the table.
Thank you.
And I said that nicely.
You did. And jokes aside, I very much appreciate the spirit of respect that I've seen in this room. So if you can keep in that direction, that would be wonderful.
Thank you. The first question or comment is from Heather Rolfried. Please go ahead.
Hi there. Can you hear me?
Yes, go ahead.
Okay, I'm sorry if I do repeat. I have Lyme, and my short-term memory is pretty bad. I'll be really quick. One thing we would like to have is sites immediately set up for communication that comes directly from the Lyme patients to those that need to know. For instance, if we could have a site for patients that can send or connect with the science minds, just to give them some ideas of things that we have seen or noticed so that they can work on them, consider them, verify them. For instance, some of us have noticed that genetic mutations, 97% of Lyme patients seem to have the same thing. So this is just like one idea. A lot of Lyme people talk about different patterns. And so this would be one site.
Okay.
Another site.
I've had your sound cut off, and I apologize for that. I'm going to turn you back on for you to wrap up in 10 seconds, because I need to move quickly from idea to idea. Go ahead.
Just the two other sites. One is for immediate reporting when we are bitten by a tick, in case the doctors, because we know they don't report, we would like to have the same opportunity. And the other one is basically the bedside manner. We want a place to be able to go immediately, say, we said we had Lyme, can we go online somewhere and not the local health authority? So those are basically what we would like to have, 3 communication links. 2 are immediate. The science one can take a little bit of time. It doesn't need to take a year, but...
Okay. Thank you. Thank you very much.
Okay.
Medium term, one idea.
We would like, we have a ton of really good ideas, so it's hard to pick one, but what the young lady Cecile just said, that we do an emergency amendment to the Health Act, or ask the...
so that's a medium term idea?
Sure.
Okay.
Because it probably can't be done right away, to begin to fund out of province and out of country valid medical care, and also to retroactively fund what people have spent.
Okay, so reimbursement. A different medium-term idea, the table at the back there.
Thank you. We had a medium-term goal to have an annual gathering with good representation from patients, the government, as well as the medical community, and that is to track the framework, the status of this framework, and also update the guidelines.
Okay. So for those on WebEx, we have 2 medium-term ideas, one on an emergency amendment to the Health Act to fund out-of-country expenses and reimbursement for those who have paid already, and then some annual gatherings to track the framework and review the guidelines. Can I have somebody on WebEx, please?
Yes, the following question or comment is from Carolyn Lennox. Please go ahead.
Hi, can you hear me okay?
Yes, go ahead.
Okay, great. We also had a whole lot of discussions on a couple of online chat groups, and I'm sorry, I was given no notification that I was queued up, so I'm going to have to just wing it. I'm just going to say one of my own, which is the immediate one, that we need to define the disease properly immediately, and that includes the role of outer surface proteins in immune function, and we need to immediately drop the Dearborn CDC case definition from the U.S., which excludes neuroborreliosis, and also we need to include co-infections in the definition of the disease.
Okay.
And never ever again go with these faulty case definitions.
Okay. Thank you. Thank you very much. All right. I have a number of tables who still have ideas to bring. I'll come to you later. What I said is I'll sample short, medium, long, and then I'll go through the room for whatever is still available. So a long-term from over here.
Hello, this is a long-term suggestion to create a center of excellence for treatment. I think this falls into short-term, long-term, and medium-term. And something that kept emerging was active participation of patients in research and the ongoing education of physicians and mandatory upgrading.
Okay. Excellent. Another long-term idea from somewhere in this side of the room? Behind you, I think, in the rows of chairs. You've got a couple of people. This one? Which one was it? Did you identify? The gray sweater behind? Okay.
The national framework should include an evaluation framework to measure the progress and success, and needs to be flexible and responsiveness to the evolving information. And doctors need access to some kind of a database for information that they can access, and link this framework to all chronic illness, and take lessons learned from Lyme and apply it to other illnesses.
Okay.
And take advantage of experienced doctors and Lyme literate doctors that actually treat the Lyme and co-infections.
Okay, I need to pause you there. I've written down 2 of your ideas. Okay. If you can hand the microphone back, please. We're just taking 1 or 2 ideas at a time per group, and then if any of your ideas have been missed later, we'll come back to you. So I wrote include an evaluation framework and a database of information for doctors. I'm going to go to WebEx for the next contribution, please.
The following question or comment is from Sherry Allen. Please go ahead.
Tick does not have to be attached for 24 hours to transmit. Just better understanding of some falsehoods that doctors are perpetuating.
Okay, so recognize that 24-hour limit is not accurate. I'm using the wrong language probably, but I'm hoping that you'll forgive me for that.
Yeah, and in the near term, reporting of bans on blood testing. I think that would be helpful rather than just a positive or negative result. And also recognition that doctors need to make patients aware that a negative blood test does not necessarily mean you don't have Lyme.
Okay.
I think that needs to be conveyed to the patient because patients don't often see those paper results.
Okay, thank you very much. I appreciate your being brief. I'll go ahead.
So this is short term.
Okay.
We would have national training of family physicians about the existence of long-term Lyme and how it relates to other chronic illnesses and how to assess and treat this disease.
Okay, so national training of family physicians. Up over here next.
This is a medium goal, 6 months to a year.
Okay.
GPs need the ability and authority to diagnose and treat, to take over this chronic condition by setting up a diverse committee split into task teams who are tasked with addressing the key topic areas that we have explored at this conference, including treatment and surveillance, etc. This committee would include healthcare professionals, including Lyme literate doctors, IDSA, NDs and GPs and researchers, along with patients who are clinically diagnosed, not necessarily tested positive in Canada, to continue this conversation to develop standardized training in a timely manner, and that it's Canadian-based.
Okay, so using a diverse committee to address many of these issues. I'm going very shorthand on the flip chart and summary, but we have fabulous note takers in the corner here capturing the details. Go ahead at the back. Here, go ahead, please.
Okay. Our recommendations are with regards to the guidelines as they exist right now. One is to remove the term endemic area from the description of when you should treat, as well as revisit the treatment that comes along with it, which currently is the doxycycline for 1 day as a preventative measure. Just to revisit that to make sure that it's evidence-based with the appropriate treatment that should be given now.
Okay, excellent, thank you.
I'd like to speak to the issue and the role of the colleges and the importance that they play on the one hand for obviously protecting the professions, but there's also the side of protecting the public. And the specific recommendation would be that they are engaged in looking at how their role, what their role is in fostering, guiding, and supporting innovation among their professionals.
So one idea would be maybe to have colleges look at how they promote innovation. Is that kind of a medium or long term?
I would say it's medium, and it is basically they are in, they are the ones who are in a sense exiting a lot of physicians because they are placing so much emphasis on protecting the profession, but in doing so, they are completely undermining their role as nurturing and developing innovation.
Okay, thank you. Where's my other microphone? At the back here, please.
To tag onto that idea, we would like to have a facility for the doctors who have lost their licenses to be reviewed and possibly reinstated, as some of the
Okay.
And apologies, as the leaders of the possible healing for Lyme. And secondly, this could be longer term. Patients, some of the patients at our table would really like to see a database of the doctors who have been Lyme denying and abusive to patients, that there would be a database set up and appropriate reactivity or process to look at their licenses.
Okay, and that kind of feeds in with the idea of the sites for communication.
Yes.
Okay, I am going to come to you next, but first I want to go to online. So WebEx, another person, please. Let me know if it's a short, medium, or long-term idea.
The following question or comment is from Sheila Stephen. Please go ahead.
Hello, I'm from British Columbia. Mine is probably a medium request, and that is that the Member of Parliament from every riding in Canada be responsible that the health, private and public sector become aware of this conference, a summary of the conference be sent to them personally.
Okay.
Thank you.
Thank you. Over here, I've got the microphone. Go. Yeah, he's going to turn you on.
I know. Oh, there we go. Something my colleague forgot to add on to the looking at college innovation is also possibly looking into working together with other colleges such as veterinary and naturopath, just to add on to that idea. And the other one is the beginnings of, this is ideally short term, but probably long term, the beginnings of collaborations with clinical researchers to investigate protocols, because in the US there's not a single research study happening with the effects of antibiotics right now. And for like professionals and respected individuals to be working in that.
Excellent, thank you. I'm coming to the middle here next.
Donc, ça serait pour du moyen terme, en fait. So, would be to maintain a budget for research on Lyme disease. And also maybe a sub-point of this, the use of a clinical database prospectively. So, yeah,
Okay.
midterm also. Thank you.
So money and prospective use of the clinical database. Merci. I'll come to you here in the front.
I think that in the short term, Canadian doctors should be allowed to communicate with the Lyme literate American doctors so that the treatment, people's treatment can continue in Canada, get all their antibiotics here, but still be able to visit the US doctor to know if any changes need to be made. But there needs to be that communication.
The communication across the border. Okay.
One other thing, can I? That Lyme should be recognized as a legitimate disability.
Is that short term?
No, that's, yes, sorry, that's short term.
Okay. I'm just, okay. I'm putting my own filter on this one. I'm just surprised it would happen that quickly, but okay. I'm going to go to WebEx again.
Thank you. The following question or comment is from Carolyn Stengel. Please go ahead.
Thank you. To elaborate just a little further on this idea of doctors who refuse to help a Lyme patient, I'd like to see an official place to report that and to see that resulting in immediate mandatory education for that doctor as a consequence.
Okay.
Because that would be the most productive way to address it. And then the second point I wanted to make was that the government of Canada create, in collaboration, equal partnership with CanLyme, a Lyme literacy hotline and website where anyone can call in, whether it's physicians or people from the general public, to get resources, referrals, and support.
Would that be short, medium, or long term, do you think?
I think those are both probably medium, although the one about doctors is fairly urgent.
Okay. And it had been put in the longer term, so I'm just going to add a notation that it could be short term as well.
I'd like to expand on some of the topics that have already been brought up. I know that some of you have mentioned research, and I just wanted to say that our group had short, medium, and long-term goals with that respect.
Okay.
And essentially, we see the necessity for an infusion of resources and funding right now in order to kickstart research, because we know that it's going to be several years before the results actually hit publication. So let's start making that available now. In the medium term, we'd like to see the opening of both the treatment center that we had proposed previously, but in collaboration with a research center, so that I know a theme that came up yesterday was the fact that it's very difficult to get well-defined cohorts, and this is an excellent opportunity. I do want to point out, though, that patients don't necessarily want to be seen just as tools, okay? So this is a collaborative initiative that involves the patient in the study, not just as an object that is being studied.
Okay.
This also involves the collection, for example, of a biobank and strategies not only to collect samples as we typically would for cancer, as an example, but also looking for ways that we have to optimize this for Lyme and tick-based infections. So, for example, to follow up on Dr. Zhang's work yesterday.
If I can stop you there.
Of course.
Let's avoid the examples. I know they bring rich information, but we'll come back to those later if we have time. Just the ideas. Go ahead. Oh,
sorry, a strategic biobank.
Okay. Thank you very much. I appreciate your patience with me.
We're long-term, but some of this could be a little gray. Vector eradication, multi-center trials, or a methodology to create them because it's such a variable illness. We would like to see autoimmunity issues brought into the loop, especially for those that have been misdiagnosed or long diagnosed with autoimmunity when it could in fact be one of these infectious triggers. The other thing, I think in this community, when we say Lyme, most of us are inclusive of all of the co-infections, et cetera. Perhaps we should be re-tagging this as something like MSIDS, Horowitz's MSIDS, something like that.
Okay, thank you. We'll stop you there. And eventually, you have a couple of hands that have been up here for a while.
Okay, we think of this short term. One thing that we need to face is it's all about the money. At the end of the day, it's all about the money. So we want to see immediate funding for short-term research.
Okay.
We want it now. We also want to see the Canada Health Act changed so those doctors who will not or don't or misdiagnose or mistreat us, I want to be able to sue them. And we can't do that here. I also want the IHC, the International Health Code, that are being used by all the provinces to include Lyme, because right now doctors get paid no matter what code they use, but it's not definitive for Lyme or any of the co-infections. And that leads to the last thing. Doctors get paid whether they screw up or not. We don't. We have to spend the money, they get paid. So we need to have a forum, which, by the way, we do. Somebody mentioned about a place to go and list doctors. I got it.
Okay, so we have that already. Thank you.
Hi, this is a medium goal that holistic medicine prescribed by NDs and MDs should be a tax write-off and not be subjected to taxation as well.
Okay, so no taxation on holistic medicine by MDs and NDs. All right, going to WebEx.
Thank you. The following question or comment is from Doris Owen. Please go ahead.
Yes, the main thing we need right now is short term is massive education of doctors, so they're not throwing out ticks and saying we don't have it here.
Okay.
We don't have Lyme here. We even in emergency rooms they're saying we don't have Lyme here.
Thank you.
In all provinces, doctors should be massively educated.
Okay. Thank you very much. So massive education of doctors, I've noted it, although remember that we are in the guidelines and sharing of best practices. Our colleagues in education and awareness should be capturing this. So let's try to focus on guidelines and best practices. I did have you cut off. I'm going to give you another 10 seconds to complete your thought. Please come back online.
Oh, it was just that they need to be reassured that they won't be harassed, and also that clinics can't turn away Lyme patients and doctors can't turn away Lyme patients.
Okay, so the protection for the doctors. Thank you very much.
Hopefully short term that there would be a website available where they could do a survey checking how much patients have spent on outside of Canada on treatment, just to see how much it really costs us. And also, so it's checking for the burden financially and also checking for job loss, and just to have that data there to check on.
So research on the financial impacts on people suffering from Lyme. Good.
Hi, I think it's short term. So immediate coverage for naturopath and prescription rights for naturopaths across Canada.
Okay, and we had something similar in the medium term around holistic
That was
medicine.
for, yeah, I believe that was for tax benefits for their prescriptions, but I'm talking about immediate prescription rights for them across Canada as they exist now in BC and other, I don't know if BC is the only province. Okay, so across Canada.
Prescription rights for naturopaths. Thank you. Over here.
Hi, my short term would be to have a conversation with what's happening in each province right now, since we've been the foot soldiers so far. Maybe we can have some common goals. And then a long term would be to develop a national team, international team for best practices worldwide. be on a committee for that.
Okay, so the sharing of best practices between provinces, short term.
We'd like this to be short-term, but suspect it may be medium-term. We would like the new guidelines to be made fairly, made without conflict of interest, with patient input and patient advocate input.
Okay, so new guidelines, fair, patient input, no conflict of interest. I'm going to go to WebEx for the next one, please.
Thank you. The following question or comment is from Catherine Leanne Morgan. Please go ahead.
Yes, hi. I wanted to make that just recently touched on a little bit, but I think that we need to reach out to the international community that is dealing with the Lyme and co-infections, researchers and also medical doctors who are treating this in Europe and in other places in the world, and find out what their best practices are, what they're doing for treatment, and how they're instituting it.
Okay, thank you very much. Who was next in the room? At the back here on my left.
As an immediate action item, in addition to prescribing authority for naturopathic doctors, I'd also like to see prescribing authority as well as diagnostic tools in relation to Lyme.
In relation to Lyme?
Correct.
Okay. Thank you. Over here.
For short term, access to a Lyme literate doctor that is available either by phone or online that doctors have access to for immediate information, and acceptance of good labs. And as a medium term, education, teaching in schools for children, and universities for students in the medical field. And also the surveillance goes beyond ticks, so recognition of other forms of transmission.
Okay, and we are moving into education and awareness, but that's all right.
We would like to see transparency and patient input into publicly funded research for Lyme disease.
Okay, did you?
That would be all short,
you know,
short,
I
medium,
think
and
what I don't want to lose these ideas, so I'm just going to continue adding ideas where they fit, and I'm not going to worry too much about whether they're short, medium, or long term. So patient input into
and
publicly funded
transparency.
research.
Yes,
and transparency.
thank you.
Okay. Who was next?
Thank you. Now, this may be like trying to catch the wind, but maybe relative control of the tick population. Like, I know we're tracking where they are, but I don't know.
So
That's just
control
one
of the
little thing.
tick population, if that's even doable.
Yeah, if that's
Let's
even
focus
doable,
on
I don't
that.
know, but that's just an idea.
Okay, thank you.
We had a discussion at our table about the need to, where does this money all going to come for research? And one of the things that we thought about is not only the cost to all of us that we've spent with treatment and tracking down a diagnosis, but what about the cost to the Canadian healthcare system as far as diagnosing us? So a cost analysis to show the public health burden and the financial burden of our health through the diagnosis, through MRIs, CTs, lumbar punctures. How much has that cost the government? And then divert some of that money, say, here's the money that we used to spend on diagnosing you, we're going to put towards research.
Okay, so look at the business case, and that ties in with the funding you've talked about in the survey of the costs as well. I'll go to WebEx for the next one.
The following question or comment is from Emily Holmes. Please go ahead.
Hi. I'm not sure if these have been covered, but just two things. Just concerning dropping the 2-tier, which would be an immediate thing. And then I know that somebody mentioned something about naturopath. I'm not sure what they said because I couldn't hear it, but there's some tests that naturopaths can't order from my understanding. I'm under treatment with a naturopath, so testing for liver and follow-up because I'm on antibiotics. Those things need to make sure that are immediately taken care of so that we're being properly followed.
Okay, so we talked about prescriptions, and you're talking about testing as well, and that might all be the same thing. I'm very ignorant on this topic. Thank you.
Yes. Once someone's diagnosed with Lyme, that they are accommodated at workplace so that they don't lose their jobs?
Okay, so workplace accommodation.
Yeah.
So we were talking about a better safe than sorry approach. So research to prove sexual transmission or mother to child or blood or saliva will take time, but warn people of the possibility for protection and prevention of transmission in the meantime. So for example, Lyme patients won't donate blood because tests and research will take time to develop.
Okay, so being cautious even before the evidence is in. Better safe than sorry. Thank you. Over here.
Long-term, just a protection of our antibiotic resources by looking at the prophylactic use of it in animal feed and stuff like that, so that we keep it for things that count.
Okay, so to try to make sure that there's not undue resistance developing on the antibiotics is what okay, thank you. I'll go to WebEx again, then I'll come to the back of the room.
Thank you. The following question or comment is from Carolyn Stengel. Please go ahead.
Thank you. I'd like to see the ITSA guidelines immediately thrown out for treatment, and instead that we adopt the ILADS guidelines for treatment. Because as we're working on creating guidelines in Canada, people are still being denied treatment based on the ITSA guidelines. So I think we should go with ILADS until we come up with something even better. Thank you.
Okay, thank you. I think that came up earlier, but I'm just jotting it down just in case. We were at the back next.
Okay, something, as a country we didn't learn from HIV. It's been sort of mentioned, but it seems to me that instantaneously we should be somehow testing our blood supply. We have been told that we could donate blood, okay? So it's in there.
Okay, so test the blood supply for Lyme. Thank you. Go ahead.
For me, okay, sorry. I'd like to see the guidelines have advice for clinicians on how to be interpreting results that come back negative in the context of the entire clinical picture, as well as guidelines on what clinicians should do when someone has persistent symptoms that aren't being treated, that aren't being relieved through use of current guidelines.
Okay, so persistent symptoms and how to interpret negative results. Go ahead at the back.
I was just going to add to the fact for testing for the blood supply for Lyme, also to include the babesiosis. There's been studies going on in the States just recently with that. But, if you have the co-infection of babesiosis and someone who had a splenectomy done and they get an organ transplant or a blood transfusion of somebody who has babesiosis, it can kill them.
Okay.
So it should be tested as well.
Testing the blood supply. Thank you. I'm not sure where we were next. Did you have somebody up here at the front? You have a second person at the back. Go ahead.
And I guess this would be long-term, that the Canadian Medical Association look at the curriculum for new medical doctors and perhaps existing doctors to include more information on nutrition than they're currently getting, and the importance of nutrition, lifestyle, et cetera.
Okay, thank you. I'll go to WebEx next.
Thank you. The following question or comment is from Sherry Allen. Please go ahead.
Thanks very much. I finally got my notes together, and I just wanted to contribute that I think it's necessary to have mandatory tick awareness programs in both the public schools and high schools, not just, letters that go out to the kids, but actual programs. And also mandatory training courses for existing doctors, not things that they can just opt into, but that are made mandatory.
Okay, so mandatory education both in the schools and for medical doctors. Go ahead over here.
Allow the acceptance of the use of other labs and their test results, even if they're not CDC positive or whatever, and the inclusion of potentially positive IgGs as also a clinical tool for diagnosis.
Okay, thank you. A wonderful array of ideas here. Okay, anybody else on WebEx? I'm not seeing any hands in the room.
Yes, the following question or comment is from Barbara Savant. Please go ahead.
My concern is to have psychologists and psychiatrists consider Lyme as a possible cause of suicide or depressive behavior in the short term, especially places like Attawabascat or other Native communities. Thank you.
Thank you.
Short.
I did have a few hands over here, and I'm seeing one here, so I'll go there first.
I just want to build on what people have commented about the clinical judgment coming into play in congruence with the diagnostics. and that sometimes people test negative and are positive, but sometimes people also test positive and are negative. So to go forward with education about what that all can mean and how important it is to have a literate physician who can walk you through all those possibilities.
So more information on the false positives and the false negatives. Okay, thank you. Over here next.
Any new guidelines should not say that Lyme is difficult to diagnose. We saw a huge in the presentations that the commonality in the complaints, and so when doctors think it's difficult, they stop trying.
Okay, thank you. Just behind you there.
Just an idea for the medium, maybe probably long term. I was thinking that there might be less of a burden on the entire medical community with Lyme if there was a set amount of doctors allotted to each province to specialize in vector-borne illnesses.
Okay. Set number of vector-borne illness specialists in each province. Over here, and then I'll come to the middle. Go ahead.
Awareness into one of the, I don't know if I would necessarily call it a co-infection, but perhaps more of an opportunistic infection, is how the damage of chlamydia pneumoniae can play in this role. I believe John Caldwell, the rich guy in the UK, came up with some stats, and that's a huge one of, it's very huge in the lineup of diseases that impact Lyme patients.
Okay, so it's another aspect on the collaboration, the making sure that all the information gets fed into the research. Yes, go ahead.
Thank you. I guess this would be a short and medium-term goal to make doctors aware that if they diagnose someone with post-treatment Lyme disease syndrome after a course of treatment by the IDS-8 guidelines, that those patients should be made aware that they may still have a chronic infection.
Okay. So PTLD does not mean that there's no chronic infection there, and they should be aware of that. Thank you. I'll go to WebEx for the next one.
Thank you. The following question or comment is from Ian Kukulski. Please go ahead.
Really quickly, just in regards to vector control or eradication that's come up, the recommendation would be to work with regulatory bodies to expedite the approval or license of safe and effective control products that would have a public health impact, such as those that would be controlling ticks.
Okay, so the products that would help to achieve that. Thank you. At the back.
Yes, I would like to include human tissue testing, including post-mortem, is vital.
Okay. Human tissue testing, including post-mortem.
Yeah, when we're talking about guidelines, I'd like to see that the psychiatric, psychological, and social aspects of Lyme disease are included in the guidelines.
Okay. Thank you.
So it's been said that the U.S. testing hasn't been researched enough in order to be used, so maybe putting a priority on doing the research and educating the doctors to it thereafter in Canada.
Okay, so if it's not been researched enough, then let's get it researched so you can validate it. Okay? Thank you. Go ahead.
I guess this kind of medium to long term, I guess. Adding in funding for research into the congenital transmission, as well as we have a need for pediatric Lyme literate specialists.
Pediatric
Lyme literate specialists.
Okay. Thank you. Thank you. I'll go to WebEx for the next, and then I'll come to my right.
Thank you. The following question or comment is from Doris Owen. Please go ahead.
Yes, my comment is short term, and it's the complaint line that's set up should also include complaints about the fact that just one person is sending in all the reports, and most of them are false positives.
Okay, so tied to the helpline and the complaints line that we've talked about already.
Something that could help all patients right now in the short term is to acknowledge the immune part of the whole illness, and things like immunoglobulins and subclasses could be tested, and intravenous IVIG could be available for people for immediate health improvements.
So acknowledge the immune aspects of the illness.
Yes.
Okay, thank you. Over here.
A lot of studies have been done that show that
there's an advantage to using more than a single antigen and more than a single strain of antigens in testing.
Okay.
And I think that needs to be examined in the context of the Canadian situation. It is being used in places like Scotland and in China.
Okay, so multiple antigens in testing. Thank you. Over at the back here.
To have resources available to teachers who are educating children that are affected by Lyme to understand exactly what the psychological and the physical aspects are of the illness that they're dealing with.
Okay, so we had mandatory education in schools, and you're talking about resources for teachers. They're linked, but they're different.
Yeah, the children need to be educated about ticks and what to do about ticks, but for those children that are infected, that can impact their learning. And so teachers need to be educated as to how to help these children so that they can continue to learn and be in a supportive environment.
Okay, so beyond the general education about risks, targeted at how to support children with Lyme. Okay, I'll go to WebEx for the next one, then I'll come to the table at the back.
The following question or comment is from Carolyn Lennox. Please go ahead.
What I'd like to see happening, and it's going to probably be medium to long term, is that the entire patient picture be included in the when the doctors are looking at it, the whole illness. So there's a GordonMedical.com has a discussion there about including things like mold and mycotoxins, looking at the whole picture. We have integrative and functional doctors that do this right now, but they have to charge privately, and they shouldn't have to charge privately $300, $400 an hour. That should be covered. And that things like the Horowitz's 16-point differential diagnostic map, which I think is going to be incorporated into ILADS, is very much about that. Let's look at the whole picture of the patient.
Okay, thank you.
And include those alternate doctors.
Okay.
Because they are doctors.
Thank you.
I think it might be very useful to have a directive to the mental health professions like psychiatrists that would indicate that there is a term called somatopsychic, which means that there are things that appear to be mental health issues, mental illness, that are in fact triggered physiologically, and that many people are being misdiagnosed and put in situations where medications are misused. Again, they are ill physically, they're given medications that actually worsen the situation for them.
So as opposed to psychosomatic, somatopsychic. Excellent, thank you. At the other side here.
Yeah, they're looking to research to develop non-toxic alternatives to DEET as a tick repellent.
Sorry, to food additives?
No, to the DEET tick repellent, we need a non-toxic alternative to that, so
Okay.
research for that.
So the alternatives to DEET. Thank you. I'll take a few more, and then I think we need to wrap up. It's time for lunch. Go ahead.
Right. This is all very, very interesting discussion. So I thought it would be good to add this treatment outcome database, and also to clearly monitor how patients really respond to the treatment, so that to avoid this, to pay attention to patients who don't respond to treatment.
Okay. So not just the treatments, but the treatment outcomes as well in the database.
It can be part of this, online database being to monitor the treatment outcome. I think that might be interesting and important.
And it sounds like there's this real theme going through a number of the ideas that have come up around the sharing of information, a capturing of information, so that it can be used to make better decisions in all kinds of contexts. Over here.
OK. Moi, madame, je vais intervenir en français et je compte sur votre expertise pour traduire.
On a des spécialistes qui sont dans la boutique. Je vais peut-être résumer en anglais pour ceux qui n'ont pas pris la peine de prendre
je vais essayer d'être assez bref. Je voudrais dire que quand on s'est présentés tous ici dimanche soir, on a vu des gens qui étaient tristes quand ils sont venus raconter leur histoire, et avec raison. Et soudainement, 3 jours plus tard, je vois des yeux rayonnants, je vois des gens avec des sourires. Et cet aspect-là, on appelle ça de l'espoir. Et ça, cet espoir-là, pour s'assurer qu'elle va être maintenue, il faudrait, à court terme, s'assurer que le genre de plénière qu'on a comme aujourd'hui devienne un événement annuel pour qu'on puisse être en mesure de mesurer les progrès qu'on va réaliser chacun chez nous et au niveau national. Il y a une autre chose qui me touche énormément, c'est de voir qu'après 3 jours, il y a toujours des experts qui sont avec nous autres. Je reconnais Dr. Zhang, Dr. Hatchett, Dr. Hawkins au fond, et j'en manque un autre ici, je ne me souviens plus de votre nom. Mais ça, cet aspect-là, de les voir encore avec nous autres après 3 jours, écouter nos plénières comme ils font, ça donne une énorme crédibilité à la démarche qu'on fait depuis 3 jours. Alors voilà.
D'accord, merci. Very briefly summarizing then, you walked in Sunday night and there was a lot of sadness, and all of a sudden there are a lot of bright eyes in the room here today. And it's a sign of hope, and to maintain that hope, let's make this an annual event. And thank you to those experts who have stuck with the process and are still in the room and listening after 3 days. It is noon. I would like to end on that high note. Is that okay? All right.